about efficacy of enhanced external counterpulsation based in patient with heart failure with reduced ejection fraction. It's a prospective and a multi-center trial. Well, the first question is why heart failure and what interested me to do a study in a heart failure? Well, heart failure is becoming an endemic process throughout the globe. It's not specific to any country but across the globe. If you look at the incidence of heart failure across the globe, it's around 63 million people are suffering from heart failure across the globe, which cost an economic burden of almost $600 billion annually. If you look at India, India doesn't have a registry for heart failure. Irrespective of it, by looking at the risk factor prevalence in the country, there are studies to show there are about 1.4 to 4.8 millions of heart failure annually across India. So this is a very sick group of population to treat with. And it has been stated heart failure is the biggest threat to our health. And actually we are reaching a stage called a tipping point. Because if it is left untreated, our economic burden on heart failure is going to rise linearly every year, about 20 to 30% increase in every year. So why the study is focused on heart failure is to create a primary care heart failure program. If you look at heart failure, there are two types. One is an acute and another is a chronic. So in acute, you need a hospitalization, but it is a chronic heart failure which erode the country's economy by creating lot of admission, readmission, and increased comorbidity with mortality and morbidity. So what we have to do is we have to create a program to treat this patient as a daycare procedure. So when you try to do a daycare procedure, there are certain things you have to look at. Prevalence. So you have to find out what is the score or how many patients of heart failure in particular society to create a heart failure program in that society. Second is outcomes. If you start to treating a patient with heart failure, we should achieve something which is an outcome. So we are able to provide improve in quality of life, decrease the rehospitalization, decrease the mortality and prolong their life and make their life acceptable. And third is quality of life. So the patient with heart failure doesn't come to the hospital to improve their ejection fraction or change their natriuretic peptide level. They came because they're not able to do routine work which is they're supposed to do at their age. When this is not achieved, their quality of life becomes very poor. So any treatment which you provide to them should be able to improve the quality of life irrespective of what you achieve objectively. And third is a cost. It's very important in India because India is very sensitive with economical rise or fall. And in any patient with heart failure, we may be able to provide a treatment which is quite acceptable for their economical status. Because if you look here, most of the patients are not covered by insurance. In spite of all this, only 5 to 10% of patients in India is covered by insurance. So when you provide a program, it should be cost effective. And this is why we thought EECP might be able to provide a cost effective solution for patients with chronic heart failure. So the next question is, yes, you want to create a program. Now we are in an era called evidence-based medicine. So you need to provide all the evidence to substantiate your claim that you're going to treat the patient and you're going to improve the outcome. So you have the potential to drive the improvement with the power to save life. So finally it comes about the mortality. If you provide a treatment, can you be able to prolong their life? It's one of the important questions in patients with heart failure. Second is aim to make prevention and management of heart failure a national health priority. So when you bring a program, slowly you should be able to provide evidence to the insurance company and health and the funding agency so that it can propagate and reach many thousands of patients. So that's the improving of heart failure care. So you involve the policymakers, healthcare professionals, professional association, organizations that fund the healthcare industry, the public caregivers and patients themselves. Now let's go to what is this heart failure really means. Now as a physician or a cardiologist, everybody at least every week they do 2 or 3 patients with heart failure who have symptoms which is enormously burdening their regular quality of life. So the definition says any patient who has symptoms or signs caused by the structural or functional inability of the myocardium to produce the blood flow to all the organs. So there is a metabolic requirement when you do a routine activity. When this metabolic requirement is not met, we call them as a patient with heart failure. And this also should corroborate with at least one of the following. It should be an elevated natriuretic peptide, or there should be a clear objective evidence of cardiogenic. There is a systemic or a pulmonary congestion. These are all the factors to decide that the patient indeed did have a heart failure. So clinically, as a physician, you see a lot of these patients comes up with symptoms after symptom, and the symptoms slowly grow. Unfortunately, in India, even with this symptom, the patient don't seek medical help because they thought heart failure as a part of their life, and they believe that because of their age, they have this symptom. I'll just give you an example. A patient walking into your clinic, initially they said swelling in their leg. That's a pedal edema. So the presentation is, I'm not able to use the same shoes, I keep changing my shoe size. Simple way to say that they have a pedal edema. And they don't care, they just leave it, and then it slowly increases because it's a fluid accumulation because of the heart inability to pump. When the fluid accumulated, slowly it started gathering into their abdomen, and they got abdominal distension. So what they complain is, they don't want to eat because even a small amount of food, the abdominal distension causes them difficult to digest and causes gastric burn, burps and all these things. And even this stage, they try to encourage themselves saying it will all be all right soon. Then the third stage is they cannot lie down and sleep because the fluid which is accumulated in the leg, in the abdomen, start accumulating in the lungs. So the lying down posture becomes so difficult and the patient starts sleeping while they are in the sitting posture. And that is a stage which is almost to reach a class 3 and class 4 symptoms. They seek the medical help. So if you look at the stages, you can see three stages. One is at risk. At risk means patient have the risk of developing heart failure, but they have not developed heart failure. So all the risk factor which is applicable for coronary artery disease, your diabetes, your hypertension, your hypercholesteremia, sedentary lifestyle, and stress, all this, and obesity, these all would be the risk and they don't have any symptom. That is stage A or at risk. Second is pre-heart failure or stage B. Patient without current or prior symptom, but they do have some abnormality in the structure. So the heart pumping function is not adequate in the echo, or they have an elevated natriuretic peptide. So there are certain signs which the physician can able to find out, but the patient is still asymptomatic. And slowly they move on to the next stage of heart failure. They become highly symptomatic. So it's a combination of stage A and stage B. They are symptomatic as well as there is a structural abnormality on the myocardium. And the heart pumping function is not adequate, and all your natriuretic peptide levels are dearranged. And finally, they come to the stage called advanced heart failure. And this is a point where my focus of studies lie down, because we believe the stage A, stage B, stage C, the patient can able to manage themselves somehow. But the stage D, they are not able to manage. They need something to be done to them, either a medication or a device-based therapy, because heart failure is a complex way of management. So there are a lot of available therapy for them. So they have to be in any one of that to get out of the stage D. So this is where our research is going to focus. Look at these patients with stage D and treat them with an effective treatment along with the optimal medical management, which are a guideline-directed medical therapy and device therapy, and add EECP as an adjuvant to this existing therapy and look at the outcome. And if you look at this, every cardiologist would be fascinated to do an echo because they know they can give a value to the cardiac function. Because every patient, it is like a numerical. They want to know something numerically how much their heart is functioning. So that's why the classification by ejection fraction. So you have a patient with heart failure with reduced ejection fraction where the heart function is less than 40%, or mildly reduced fraction which is 41 to 49%, or with preserved ejection fraction. And thus the heart pumping is absolutely normal. So the contraction is normal, but the relaxation has failed. So this is a preserved LV function. And the fourth category is what calls heart failure with improved ejection fraction. It is a unique classification because initially we thought heart failure is a one-way street. You go down the heart failure, you will never recover. Your pumping function keeps on, stage by stage is going to reduce. But recent evidence-based medicine have shown there is a fourth stage when some patient, they may be able to recover the heart pumping function back. May not be normal, but there is significant improvement in the pumping function. So our focus is to see this heart failure with reduced ejection fraction and applying our hypothesis by doing what we believe that EECP can offer to the patient, shift this patient from here to heart failure with improved ejection fraction. This is what we are going to talk about in detail. Now, what is a gap? So if there is so much of medications and device-based therapy already for heart failure, what is there is a gap that we have to fill in? Because it's a polypharmacy. You have like a simple medication for your coronary artery disease, and then we add up some medical management for heart failure. Specifically, we call it as a 4-pillar. You have to be on a AC inhibitor or ARB or ARNI, or it can be a beta blocker, then MRA, and then now SGL2 inhibitor. So all this medication the patients are already on, and in spite of this patient is not able to recover, you have device-based therapies. You have CRT and you have cardiac resynchronization therapy. In spite of all this, you can see about here, this is a presentation which is done from the Medicare in USA, and it is across the globe, Europe and Italy and Spain. You look at here, it is a very alarming figure. Every 30 days after hospitalization, the patient gets hospitalized for heart failure. After 30 days, the rehospitalization is from 24% to 22, 24, 27, 38, and in a period of almost 6 to 9 months, 60% are again repeatedly hospitalized. Now, the repeated hospitalization, 50% of the time is because of the same reason why they got hospitalized previously. So, the repeat hospitalization is a great concern in US. In fact, the Medicare have come up with a policy of asking the hospital, if they don't keep the rehospitalization rate low, they may not reimburse the treatment cost for the patient. It went up to that level. But the reason is, you can see, the mortality of heart failure has significantly reduced, as well as life has been prolonged. The lifetime of the patient, even free survival, that they can be lived for a longer period of time without going to hospitalization, is also has improved because of the drug management. You can have ACE inhibitor, beta blocker, MRA and ARB. They all together about 16 to 20 to 30% reduction in the mortality rate. And now newer drugs like ARNA, angiotensin receptor nephrolysin inhibitor, and also we have another drug, SG, sodium glucose cotransport inhibitor. These are all the newer drugs, further reduces the mortality. But in spite of that, the rehospitalization rate is still a concern even in 2022. Well, what would be the reason for it? Now, the reason is, number one, a cardiologist or a physician were unable to achieve the guideline-directed medical therapy, or optimal dosage could not be achieved in heart failure patient. Why is it so? Because of the poor pumping function, many times this drug may cause us other effects. Sometimes a patient may be in tachycardia or bradycardia, hypotension, or they have a high creatinine level, which they also have a hepatic problem or renal problem, and have hyponatremia, hyperkalemia. All these things put together will not make the doctors to optimize the drug to the maximum optimal level, which could be achieved in a patient with heart failure. So, failure of the medication to achieve the optimal level. Second is patient reluctance to move towards device-based therapy. So, when the medication doesn't work, then you have to talk about CRT and you have to talk about a cardio defibrillator, and all these aspects the patients are not willing because of the economical constraint. So, it is very specific to India. The second point is very specific to India. And third is adherence to the strict lifestyle. Once the patient get out of the hospital, immediately think they get over the problem and they are fine. And then their lifestyle changes which could not be implemented. They take over salt, drug is not monitored, increase water intake, leading them to the heart failure again. And then be sufficed. Heart failure is actually a systemic problem. When you have a failed heart, you have a neurohormonal imbalance, you have an electrolyte imbalance, you have a renal imbalance, you have a hepatic imbalance. So you may not be able to address all this comorbidity while on admission, and that could be another reason where the rehospitalization is high. So with that, I would put up a current background, and we will summarize in a two simple snapshot. Patients who are hospitalized for heart failure, post-discharge rehospitalization is very high, around 25% in 30 days, and 30% in 90 days, and up to 50 to 60% in 6 months. And the evidence-based medical management and device-based medical management fail to reduce the high rehospitalization rate. So that is why we bring out a thesis to address this gap, to see whether we can able to achieve something which is not been achieved with so much of polypharmacy and device-based therapy. So we put a hypothesis. We designed the trial to combine what we call enhanced external counterpulsation with a standard medical management for heart failure. It's a combination. It is an adjuvant treatment with an existing treatment. Second is we check our hypothesis by combining this, could be able to reduce the rehospitalization rate. That is a primary endpoint. This is what we want to achieve in this specific group of population who are called heart failure. In that we are talking about a subgroup of patient called heart failure with reduced ejection fraction. Now, when I speak so much, so you should know about what is actually called enhanced external counterpulsation. Enhanced external counterpulsation, it is a non-surgical option or is a mechanical option to improve the myocardial perfusion without patient undergoing for a mechanical revascularization. So here you can see the patient lie down on the treatment table, 3 sets of cuffs are tied and the patient is hooked to the ECG. So what it does is, it reverses the blood flow from the lower limb towards the upper part of the body. So it changes the hemodynamics in the central hemodynamics so that the blood to the heart muscle can be enhanced. So the treatment is a stimulus. The stimulus is very similar to what you can achieve by an aggressive exercise. But it can be done passively without straining your myocardium or heart, because you have a failing heart, you cannot able to stress it. So you may able to increase the blood flow without straining the heart. At the same time, we may have this effect because exercise improves everything. It can improve your renal function, it can improve your liver function, it can improve the blood flow to the heart. So this is what EECP can able to play as a systemic troubleshooter than localized troubleshooter. So the treatment is for 35. The stimulus is given continuously every day, 1 hour for 35 consecutive days, so that we're going to look at how your body responds to the stimulus, which is consistent for 35 days. So this is a small figure to show. You can see when you're lying down posture, 60% of the blood is pooled into your lower limb. Of course, if you have heart failure, it is much more than 60% is going to be pooled in your lower limb. So you put a compressive bandage, the lower cuff, lower thigh and upper thigh region, get to the EKG, and then when you compress, you're going to compress 2 compartments. One is an arterial and one is a venous. When the venous compartment is compressed, is a natural retrograde blood flow. It is going to increase the blood flow, which is a preload, increasing to the right atrium, it is increasing the right ventricle, it goes to the pulmonary circulation, and finally it end up come back to the left side and increases the stroke volume or cardiac output. So passively you can able to improve the stroke volume. And second is arterial compression. So it is timed, as I said, is ECG gated. So exactly during the time where your aortic valve is closed in the cardiac cycle, the cuff inflates. When it inflates, the retrograde blood flow, when it reaches the aorta, root of the aorta, the valve is closed. So the only pathway the blood can enter is into the coronary vessel. So it increases the flow specifically into the coronary vessels, and it can cause us a flow increase into the myocardium when opening the dormant channels or a collateral channels. And second is deflation. When you inflate the cuff, you have to also deflate the cuff. So when the heart is in the systolic phase, when the heart is trying to eject the blood into the systemic circulation, your cuff deflate, creating a negative suction effect, so it can receive the blood flow with less effort. So the myocardium is not going to strain that much as it is supposed to be or it is doing before the starting of the treatment. So there is a reduction in myocardial demand, or the effort of myocardium is reduced so that the flow to the periphery can be increased. So combining with the increased preload and significant reduction in afterload, the final thing you achieve is an increased cardiac output or stroke volume, which is very important in patients with heart failure. To summarize here, step 1, step 2, step 3, step 4. Step 1 is retrograde aortic flow, so the coronary perfusion pressure is increased. When the coronary perfusion pressure is increased, the flow and the velocity start to happen. It creates some kind of a hypertensive response into the vascular bed. So the vasculature responded by forming lot of collateral, and it stimulates what we call as an angiogenesis. Second is increased venous return can causes cardiac output. Third is as a blood flow increases across the body, because a heart failure patient, we call it as a stasis. The blood flow throughout the body is so slow because of the pumping efficacy is low. And suddenly when the flow increases, it stimulates lot of endothelial hormones. Important is nitric oxide, which can keep your vessel healthy and dilated. And also it can reduce the systemic vasculature. As I said, the left ventricular afterload and oxygen demand significantly drops. Now, heart failure and rehospitalization, that is a talk. So if you do EECP for 35 days and you can preserve the patient without going to the hospital, but after that what happened? You stop the treatment, but what we call as a chronic cardiovascular adaptation. So when you give the stimulus or exercise stimulus continuously for 35 days, your body responds. Your body responds by arterial remodeling, or the vessel become elastic, or the vessel can able to dilate much better. So it decreases the arterial stiffness. Second is endothelial function recovery. One of the important parameters which decide your rehospitalization right, whether it is a coronary artery disease or a heart failure, is the functionality of endothelium to secrete hormone which can dilate your vessel, which is a nitric oxide. So if the nitric oxide is secreted, your endothelial cells become active and the vessel can dilate. And if you can able to achieve this, your vessel dilates and it can improve what we call as a ventricular vascular coupling. So your heart is going to speak to your vessel and your vessel is going to speak to your heart. So there is a good compliance. So that will not put your heart at stress. The vessel can able to receive the blood without stressing the myocardium. And third is cardiovascular regeneration. Because of the chronic stimulus, just like an exercise, your body responds by throwing lot of cells. One of the important cells is endothelial progenerated cell. These cells actually can able to repair the dead myocardium to some extent or improve the vasculature. And finally, the peripheral vascular training. So because of the consistent inflation and deflation in a cyclic manner, your peripheral training effect or the vessel dilates and then reduces significantly the peripheral vascular resistance. So we are speculating a mechanism before even going to the study how this EECP may help this patient with severe heart failure. So you look at this. This is what the heart failure cycle is about. There is an injury to the myocardium. Because of the injury to the myocardium is not going to contract as good as it is supposed to be. So there is a decrease in stroke volume and cardiac output. This causes poor endothelial function, and this poor endothelial function and reduced blood flow stimulate RAS, renin-angiotensin axis, and also stimulate the nervous system, sympathetic tone, and all this eventually as a protective mechanism to keep you safe eventually fails and causes the opposite effect, hypertrophy and fibrosis. So here EECP would have the effect in all the stages. It can able to when there is a reduction in cardiac output, it can increase your cardiac output. When there is endothelial damage, it can improve the endothelial. When there is a RAS is activated, it can inhibit the RAS. It can able to reduce the sympathetic activity and improve the contractility. And overall, you provide a blood flow to the heart muscle and improve the quality of life of the patient, which is a paramount important in patient with heart failure. Now, previously there are a couple of trials which was done in EECP, which is took from the registry in US in Pittsburgh. They looked at patients in the registry who have multiple rehospitalization in 6 months, and these patients invariably they gone for a EECP, and after EECP they followed for the next 6 months, and they found out there is a significant reduction in emergency visit reduction and also rehospitalization visit, 83% reduction in hospitalization. And if you look at the cost also significantly reduced. The Medicare cost for keeping the heart failure patient outside the hospital significantly reduced if they undergone a heart failure program. And then there is a 2 years follow-up. And here is what we are deriving some important message for our study. If you look at here, the 2 years follow-up of patient with severe LV dysfunction after they undergone EECP, the survival looks better. 2 years survival rate is almost 83%, which is very good in patient with heart failure. And if you look at during the EECP, you find out exacerbation means if the patient who have heart failure, when you do EECP with volume overload, you increase the preload and causes pulmonary edema. And this happens in almost 3.3% of the patient who was going EECP, and MACE, major adverse cardiac event, in 1.9. So altogether, some of them become severely unstable that they're going to go for a mechanical intervention, PCI or CABG. So if you look at that, this group of patient does have a high risk during EECP procedure. So it's about 6 to 7% they have a complication while EECP. So in our thesis, we looked out for a method to avoid this complication during procedure by altering the cuff inflation and deflation timing. Now this is the reason one of our colleague in US, in Chicago, he presented the paper that the expected line, if you don't go for EECP, your expected line of rehospitalization is 34%. But after EECP, he's shown that he can able to reduce it to 6.1%. That is a four times reduction in the rehospitalization rate. Now, in our method, we looked at more than 150 patients we screened, because here in this trial, we are going to focus about a small subgroup of patients who is going to be very, very sick and need a lot of hospitalization. This is heart failure with reduced ejection fraction with symptom 3 to symptom 4, and they should come on stage D, which I have mentioned earlier. So when you screen more than 150 patients, we are able to get 45 patients with all these criteria applied. So the clinical relevance of the trial is this trial will help to manage heart failure patient effectively through EECP along standard heart failure medical management. Positive result, if we can able to show, will be the first study to show the reduction in rehospitalization rate in patient with heart failure. And the patient would also, as a secondary endpoint, should show the improvement in quality of life, improve in exercise tolerance, reduce myocardial ischemic burden, rehospitalization and mortality. And this will also significantly reduce the cost on the patient and the patient can able to utilize better limited resources in the cardiology department. Now, the trial has two endpoints. One is a primary endpoint, which is our paramount, which is the rehospitalization rate. So we looked at 30, 60, 90, and 6 months of rehospitalization rate, both cardiac and non-cardiac. So we call it as the all-cause mortality rate. And secondary endpoint, we look at the quality of life, which is assessed by Minnesota Heart Failure Questionnaire and also by New York Heart Association. And second is functional class improvement, which is both comes under the quality of life, and the 6 minutes walk test, LV function, and serum urea creatinine, C-reactive protein, and as well as NT-proBNP. Now, if you go the schematic diagram, we screen the patient. So 150 patients has been screened, and patient has been chosen which fall into the criteria of our research setting, and then their baseline, the symptoms, the quality of life, the echocardiography is repeated if it is not done 2 weeks prior, and the patient's urea and creatinines are taken, because most of the patients with heart failure end up in what we call as a cardiorenal syndrome. So they also have an impairment of renal function. So we want to make sure there is no severe renal impairment which may able to get them for dialysis. So we want to keep the creatinine level a little bit lower, and also NT-proBNP, which is a marker which shows the strain of the left ventricle. And then the post-treatment, and we go for the EECP, and post-treatment, again, the same symptom, quality of life, echo, urea, and 6 minutes walk test is repeated. And at the 6 months, again, the patient undergoes the symptoms, quality of life, echo, serum urea creatinine, CRP, 6 minutes walk test, and the NT-proBNP. Now, we have an inclusion criteria. So patient anywhere between 25 to 85 years, anyone would be a candidate for EECP. Our youngest age group is around 31 and the older is 83 years. And patient should be able to give a consent to participate in the study. The patient with symptomatic ischemic cardiomyopathy, so they should have a history of AMI, and they should have a proven patient who have a ischemia or a coronary artery disease. And they have a NHS class 2 to class 4. Patients who have ischemic cardiomyopathy should have proven coronary artery disease at least one following criteria. So they should have undergone an angiogram, they should have at least one vessel with epicardial stenosis greater than 70%, and the exercise treadmill should be positive for inducible ischemia, and they should have a history of myocardial infarction, and a nuclear scan, rest myocardial perfusion should show the rest ischemia or reversible ischemia, and of course the LV function should be less than or equal to 40%, and the patient should be stable on optimal medical management with no change in medical management at least for 2 weeks, and the patient should have been hospitalized for heart failure prior 1 year before going for the trial. And the serum creatinine, we kept it as a marker of less than 1.5. And exclusion. So some of these patients may not come under this purview of this research, so has to be excluded from the study. So if they have an acute coronary syndrome within the past 1 month, they should be taken out of the study group. And if any cardiac catheterization done prior to 1 week, or they have a history of deep vein thrombosis, because deep vein thrombosis may, when we put the cuff pressure, may dislodge and may cause a pulmonary infarct. So we just want to make sure they are not in the group of patients who are studying. And clinically significant valvular heart disease. So it changes the hemodynamics. So we don't want to have any patient with severe valvular stenosis, because the heart failure because of severe valvular stenosis doesn't come under our purview. It goes for an interventional procedure where the valve replacement has to be done. And any patient with severe bleeding diastasis, and of course patient with uncontrolled hypertension. And anything PTCA or CABG within 3 months, because we are worried about they are a high risk group, so we want to wait until they cross the 3 months post CABG and post PTCA. And then patient with aortic aneurysm, because we are going to compress the vessel in the lower limb, reverse the blood flow, and so we are very careful that the patient doesn't have any aneurysm in the aorta, whether descending, ascending aorta, so that or any history of aneurysm repair. And patient with severe aortic regurgitation. Of course, these patients, when you push the blood, the valve cannot hold the blood. It may get into the left ventricle rather than our destination of coronary artery. So they should be excluded. And patient with arrhythmias, severe arrhythmias, where we may not be able to gate and do the treatment correctly because of the arrhythmic, irregular QRS complex. So they can be taken out. And patient with severe pulmonary hypertension and pregnant women. So relative contraindication, in spite of this contraindication, some of the patients we still recruit in the trial. For example, when they have a bleeding diastasis, we make the INR and we make sure it is less than 2.5. And then if there is a severe arrhythmia, we try to manage them with medical management, control the lateral fibrillation or flutter with medical management, and then try to put them on the EECP. And if there is uncontrolled hypertension, anyway, it's relative. So we may able to bring down the blood pressure before placing for the EECP. Or even with patient with deep vein thrombosis history, we do the Doppler to rule out currently if they do have a deep vein thrombosis or it's not there. So now we come to the EECP heart failure protocol. As I mentioned before, the initial studies have clearly shown in patient with heart failure, you attempted EECP, there is a 7 to 8% of worsening of the cardiac failure during the procedure. So we want to implement a protocol where this could be avoided. Then only we can able to reduce the rehospitalization risk. Now, traditionally, if you look at any patient, any cardiologist with the management of heart failure, they are very clear on two things. The heart failure pharmacotherapy management depends upon decreasing the preload. So they give you some vasodilators. It's a veno or an arterial dilator, which can able to reduce the preload as well as reduce the afterload. So once it is both reduced, they can add another drug which can able to improve the ionotropic effect or a muscular contraction, like lanoxin. So all these things combined, they may able to increase the stroke volume without worsening the heart failure symptoms. So that is how a pharmacotherapy play a major role. But of course, EECP, there is a significant change because the problem is when you compress a lower limb, you're going to increase the preload, which is opposite to what they are doing. But now recent evidence have shown, even though there is an increase in preload, the afterload reduction which you achieve during EECP is much, much better than anything you can achieve by drug management. So the significant reduction in afterload, and also because of the increased myocardial blood flow and the myocardial ionotropic effect is also predominant, finally we may able to increase the similar stroke volume even with the increased preload and decrease afterload and by increasing the myocardial contraction. And then in our protocol, what we do is, this is a protocol universally followed across the globe, which is a normal LV function is applied for heart failure also. But where we differ here, what we do is, in many patients with heart failure, irrespective of them on the maximum diuretic dosages, they still have some retention of fluid, mild to moderate. And because they are not responding to the diuresis anymore or they become diuretic resistant. So in this group of patients, we don't go with a small, slow incremental pressure. We go with a fast incremental pressure. From 80, we jump to 160 and 220 to 260 within 3 minutes. Because the compression is not only required for preload, the relaxation of the cuff is required for the afterload reduction. So after that, the physician or the therapist are trained to monitor for new onset of ectopics, drop in SpO2 level, bradycardia, tachycardia, lung sign, cough, shortness of breath or chest discomforts. Any of these things we immediately address during the procedure. Now here it is. You have a patient with low EF which is less than 40%. We start the pressure with 120 and in 5 minutes we reach 220 to 240. So if the saturation drops below 96, then we'll give them oxygen of 2 to 4 liters per minute. And if the saturation is stable, then we continue EECP. And then the timing is, we time the cuff a little bit early. So I'm going to come to this why we do a early deflation. Now you have to be very careful in patient with pulmonary artery pressure greater than 50 millimeter mercury, pulmonary hypertension, and patient with volume overload. So we do all effort to diurese them before putting them on a EECP. And predominantly right heart failure symptoms also is difficult to treat. We have to be careful. And then by monitoring oxygen, we can able to see whether tachycardia, hypotension and weight gain has to be monitored during the procedure. So here what we do. In patient with normal pumping function, when we do EECP, when there is a sudden cuff deflation, the heart is able to pump easily into the periphery. So the systolic amplitude, the power of the muscle contraction mildly comes down. This can be seen on the screen by reduction in peak systolic pressure. At the same time, there is a reduction in end-diastolic pressure. The reduction in end-diastolic pressure helps the heart to fill easily. That is a filling pressure of the left ventricle. But in heart failure patient, we tend to keep the peak systolic pressure similar to the control strip. We don't want to alter. The reason is when you increase the preload, naturally the heart starts to contract much better and causes increased stroke volume. So the increased peak systolic pressure in heart failure patient is predominantly because of the increased contraction power of the myocardium rather than the afterload reduction. But to keep the afterload reduction, we keep a check on the end-diastolic pressure. This end-diastolic pressure reduction is again signifies the afterload reduction. So here is the two strips we have taken. When you do the deflation yearly,
you can see this is the unassisted waveform where there is no EECPs provided. This is the assisted waveform. So you can see the systolic amplitude and then the diastolic augmentation. You can see the systolic amplitude is reduced. So there is an afterload reduction with the early deflation. The same thing if you go for very early deflation, you can see the systolic amplitude actually rises. This is the baseline. If you look at the height, is much higher than the patient with the unassisted. So here we have to be very careful in doing the treatment, that we have to make sure the assisted systolic peak should be the same height of the unassisted systolic peak, but the end diastolic pressure should be deeper than the unassisted wave. So we achieve the afterload reduction and we also increase the stroke volume. So the rationale behind the cuff. So why did you choose to do the cuff inflation and deflation something different? Now if you look at this, there are some studies which is done in invasively to look at the right atrial pressure, pulmonary capillary pressure and cardiac index. Now we look at here, it's very interesting. Baseline 15 minutes, 30, 45 minutes. As a treatment progress, when you start the treatment, your right atrial pressure shoots up. That shows your preload is started to increase. And if these patients have a pulmonary hypertension, they're going to go for a pulmonary edema. But 15 to 20 minutes, you monitor the patient slowly, and after that, it started dropping down. Because of the afterload reduction, the cardiac stroke volume increases, so the right atrial pressure drops down. See the similar pattern happen in the capillary pulmonary wedge pressure. The wedge pressure goes up and significantly reduces. By the end of 45 minutes, it's much lower, and by the end of the 16 minutes, it's much lower than the baseline itself. These are all because could be explained. You can see the cardiac index or the cardiac output significantly increase as the time passes. So you have to be careful in the first 30 minutes or 15 minutes. And so if you do the deflation timing little bit earlier and assist the heart, you may not be able to end up the patient with heart failure. And this management reflect in our study results, which none of them develop pulmonary edema during the procedure. Now the cuff pressure also we choose. There are 4 types of cuff pressure which we are following. One is a cuff, one is a lower cuff, low cuff and thigh, and second is a thigh buttock, and third is a 3 cuff. In that we choose to put off the lower cuff in patient with volume overload. When you put off the lower cuff in the EECP mission, what really happens is your preload significantly reduced. You are not going to increase significant amount of preload, but the afterload reduction is very high. If you can see the same two cuff high mode, if you look at here, the green shows in that there is a significant reduction in left ventricular end diastolic pressure. It shows the afterload reduction is significant and the filling pressure is great. So the heart can able to receive the blood and the cavity is filled with blood and the cardiac output can increase. So with that, we come to the background. We're going to study the clinical response, objective and subjective in our study, and how we're going to relate it with our change in protocol. Now in this study, the mean age is around 56. This is a fairly young age group of patient. And if you look at the patient, 81% of them are male, and 27% has a family history of CAD, and 62% of them are diabetic, which is my higher incidence of diabetic. In any trial, it is around 40 to 50, but here it around 62% are diabetic, and 29% of hypertensive, and 29% have smoking history, and almost all had a history of MI. So it's a group specifically of ischemic cardiomyopathy, and 20% has previously attempted PTCA and CABG, and almost 47 had a CAG, and in that 46% has a triple vessel disease. So the first is a diastolic augmentation. So this is how we measure the diastolic augmentation. In our trial, we have shown the diastolic augmentation is much greater. So this is a systole because of the compression of the lower vessel during the diastolic phase. Rather than the downsloping, there is an upstroke. The diastole should fall, but it is upstroke. The upstroke is because of the significant increase in the reverse blood flow, which is happening in your leg as well into the central hemodynamic circulation. So this is how we measure the systole-diastole ratio, DS ratio. So if you can see 4 square tall, 2 square. So 4 divided is 2. So the diastolic augmentation 2 means you are significantly improve the blood flow to the central hemodynamics. So your coronary perfusion and the coronary velocity and flow are significantly increased at least 2-fold. And the area calculation is the area of the under the D curve divided by the area under the S curve. So it is around 7 divided by 3, 8 divided by 3. So this ratio is what it's going to indirectly give you the evidence that you are treating the patient and you are increasing the coronary blood flow. So the augmentation ratio. You can see the augmentation ratio. To start the treatment, we have 0.98, and then the middle of the treatment it is 1.5, and the end of the treatment is 1.88. So there is a linear increase in the diastolic augmentation. So the patient, as a treatment progress, is keep increasing. So this is what we have looked at the beginning, mid, and end. As a treatment progress, the vessels become so compliant, the peripheral resistance dropped, your preload is going to increase, cardiac output is increased, and there is a linear increase in the A value. The peak value, the peak amplitude value also significantly increased. This shows during the procedure, the patient significantly improved the cardiac output as well as the blood flow to the coronary vessels. Now, second is we looked at the functional ability. As I said, what the patient wants is not about the blood flow, it is the quality of life. So the functional classification is New York Heart Association Class 1, Class 2, Class 3, and Class 4. Class 1 is they don't have any limitation. They are very fine. They don't have any symptom. Class 2 is they are not able to do some work which they used to do before. For example, somebody used to do around 2 kilometers of walking, which is not able to which you are not able to do now. That is Class 2. Class 3 is routine activity which everybody is supposed to do. Walking inside the house, taking a bath, brushing your teeth, even that becomes a problem is a Class 3. And Class 4 is severe. Even in rest he has symptoms. So we also grade the same grade 1, grade 2, and grade 3. So in our study, if you look at pre-EECP, 2.62. Most of our patients, I think 40 to 50% of the patients are in Class 3 and Class 4. That shows they are a sick group of population with optimal medical management, or the optimal medical management couldn't be achieved because of drug complexity or a comorbid illness or the adverse effect. So in this group of patients with highly symptomatic post-EECP, there is a significant drop. So now they are able to walk, they can able to do their exercise as before, and they are not as symptomatic as they are supposed to be with that ejection fraction. And then we followed them up to 6 months. Even after the following 6 months, they retain the benefit. This is called the chronic cardiovascular adaptation for a stimulus which is lasting for 35 days. Now, we also want to assess, it's a quality of life assessment is tricky. Asking a patient whether you are fine, it's one question, but another is asking them to do an exercise, and measuring the exercise ability is considered as a gold standard in patient with heart failure. So the 6 minutes walk test is considered as a gold standard, because if that doesn't improve, the patient is not improving. So here we do a 6 minutes, which is a 100-foot corridor, and we ask them to walk in a loop, and we will ask them to every lap. He was able to note the time. So after 6 minutes, how much exercise or how much distance he covered in that lap. Line is around 300 meters. So this shows the patient to start with or with a poor quality of life with poor exercise tolerance. The poor exercise tolerance is a hallmark for heart failure. Because of the poor cardiac output, they have lactic acid accumulation in the not only in the skeletal muscle, which prevent them to do exercise. So here there is a significantly lower exercise effort tolerance. But post-EECP, it increased significantly to 347, and even in 6 months, it's sustained in this patient. And then another one is what we call as a NT-proBNP. Now, the heart failure has become very important with the advent of NT-proBNP. NT-proBNP is a peptide which is secreted because of there is a strain in the myocardium. If there is a strain, the heart is tend to produce this NT-proBNP, and this causes natriuresis, it causes diuresis, and it's also improve the outcome in a short time. But if it is chronically increased, the NT-proBNP, it become a marker for worsening of heart failure. Patients who have a high NT-proBNP tend to have a higher rehospitalization, higher mortality, higher chance of getting into myocardial infarction. So here, our baseline itself, we are very clear, because we took a sick group. None of the trial, even the recent trial of Emperor and DAPA, all of them are done for SGL2 inhibitor and ARNI. They have a baseline of 1,500 to 1,600. In our case, the baseline is almost 2,367. And after the treatment, there is a considerable reduction in NT-proBNP to 1,627. Even in 6 months, the reduction is maintained. In fact, the pre and post EECP reduction is around 23%, 23 to 30%, but in the 6 months, it is about 45% reduction. So there is only one study to see around 35% reduction in NT-proBNP in patients who are taking the SGL2 inhibitor. So without drug management, we were able to achieve that, and it has been lasting longer than after we stop the treatment. And the LVF, left ventricular ejection fraction, is another hallmark. Here we can see Initially, the patient started with a poor LV function, around 30%, 30 to 31%, and post EECP, there is significant improvement in the LVF from 31 to 38, which is around 23%, and even 6 months, the LVF is maintained. And then the CRP, and this CRP we took because we are concerned. When we increase the blood flow to the myocardium, it is going to go systemically. All the systemic arteries are going to expose to the shear stress of this increased blood volume moving across your body. Would that cause any inflammation response in your body? So we looked at the CRP level to see if there is any inflammatory response. Of course, the CRP level in fact has decreased. So it shows EECP might only have an anti-inflammatory effect rather than an actual inflammatory effect. And this reduction is also sustained even for 6 months. And patient with EECP, as I said, we want to rule out the cardiorenal, and initially in our inclusion criteria, we restricted this group to 1.5. So basically our urea and creatinine level comes under the normal range. So even this patient, none of them actually in an acute renal failure or in chronic renal failure. So we did see a trend of reduction but did not reach statistical significance. So your urea and your creatinine level showed significant reduction, shows some reduction, but that did not reach the statistical significant level, which could be explained. We can able to correct an abnormality towards normal, but you're going to make a normal to supernormal. So definitely there is a trend towards reduction. And I think in 15% of the people that has a renal problem, which the creatinine level is 1.3 to 1.4. Now the important thing is the clinical outcome. So during the procedure, none of them has worsened or admitted for heart failure during the 35 days of EECP procedure, or none of them required to administer IV Lasix or dopamine during the procedure. That shows the timing mechanism does work to reduce the incidence of worsening of heart failure during the procedure. And then if you look at the population of patients you have choose in the inclusion criteria, almost 67% of them are at least have two hospitalization for LVF predominantly, because 80% have pulmonary edema, left ventricular failure, and 10% before starting EECP have admission for anemia complication, and 5% have pneumonia which worsen the heart failure, and another 5% has urinary tract infection which worsen the heart failure. So after 35 days of EECP, we followed the patient for 3 months and 6 months. There was no mortality, no hospitalization in 6 months. So this is a very significant, even though the number is lower, we expect this is highly significant because the rehospitalization rate is every 1 patient is expected to get rehospitalization in 6 months. But in our trial of 45 patients, none got rehospitalization in 6 months. To summarize the result, the EECP 35 session has improved subjective and objective parameter, and the improvement in subjective and objective parameter was sustained even after 6 months of completion of the treatment. The NYH and 6 minutes walk test clearly shows a subjective evidence to show that effort tolerance or exercise tolerance or quality of life has improved, and the NT-proBNP and LVF, which does correlate. The patient with high NT-proBNP has a low ejection fraction, vice versa, reverse, and the CRP, urea creatinine. So you have a subjective and objective evidence. All our secondary endpoints are met with our positive trial, and also our primary endpoint, which is a mortality, is also as a positive. So this trial is positive to show EECP as given as an adjuvant in patient with heart failure who are on maximal tolerant medical therapy and who are not an eligible candidate for aggressive device-based medical therapy, would significantly lower their rehospitalization rate, reduce the mortality, improve the survival. This is also in reflection with LV function. So as a discussion, I want to say the study results show a complete improved after EECP. The improved functional ability and exercise tolerance achieved with EECP treatment will significantly enhance the quality of life and possibly reduce the depression and mortality. So many of the patients, they are elated because of heart failure we do monitor, that's a sub-study, most of them are in the depression. But here the patients feel fine because we are trying something which is non-invasive and it is not cumbersome and it is very easy to undergo. And third is the EECP has exercise tolerance improved up to 6 months, and the improvement is about 90% is maintained in 6 months. And EECP, due to its pulsatile increased retrograde arterial blood flow, will cause a cyclic shear stress to the vascular endothelium. And we have proven by showing the CRP level has not altered. In fact, it is reduced. It does not have an inflammatory effect. It does have an anti-inflammatory effect. The reduction in NT-proBNP level of 45% in 6 months is very significant when compared to other newer drugs like ARNI, which is done in a paradigm heart failure trial. The EECP positive effect on myocardium, renal, and systemic vascular response is unique in heart failure management. The 35% of heart failure patients improved greater and equal to 10 points. This is what I said. So the 35% of the patient with have a poor LV function or LV function less than 40% tend to go to the heart failure with improved ejection fraction, more than 10 points improved, and they crossed the 40% and gone beyond the 40%. So EECP is a first non-surgical, non-pharmacological, mechanical device-based therapy for heart failure. So in our study, the baseline LVF of 31% and NT-proBNP greater than 200 ml picograms shows these patient studies have advanced heart failure and with moderate to severe congestion. Because that level of NT-proBNP, they do have a residual pedal edema and abdominal distension in spite of them on maximal drug therapy. The post-treatment LVF improved to 23% and NT-proBNP reduced 31%. This significant improvement post-EECP was sustained even after 6 months of stopping the treatment. The NT-proBNP showed further reduction during 6 months up to 45% compared to the baseline. So we may put a small conclusion for the trial as a take-home message. Enhance external counterpatient and act as an adjuvant and supportive therapy for heart patient with ischemic heart failure with reduced ejection fraction. The treatment can significantly improve heart failure with reduced ejection patient exercise tolerance, left ventricular function, and significantly improve the quality of life. These benefits of EECP treatment can be directly attributed to improving myocardial blood flow and normalization of endovascular stone. This I can derive because all these patients are ischemic and their improvement is also reflected in improvement in LV function, and also the normalization of vascular stone is because of the natriuretic peptides, your NT-proBNP reduction. This observed effect was sustained for 6 months post-treatment, significantly reducing the rehospitalization rate and mortality of these patients. So our publication, the initial 6 minutes walk test was accepted for a presentation and was presented in American College of Cardiology in 2020. And the manuscript for 6 minutes and NT-proBNP were presented in the Biomedicine Journal as efficacy of enhanced external counterpulsation in improving 6-minute walk test in heart failure patient. And the protocol which I have adapted in this thesis, how we should be able to help heart failure patient by changing the protocol in the equipment with the inflation, deflation, and how to change the cuff setting has been detailedly studied and has been published as a textbook in clinical cardiology.
No hospitalization, no pain, no surgery, and highly cost effective.